Hi, this is Clay Josephi, and we're here to return to our topic of alcohol withdrawal syndrome. So, the focus of part two of this lecture series is the protocol for Barton Health Systems. And this is an introduction and a discussion of that protocol. So, if you haven't listened to part one, it's kind of long and arduous, but I recommend you take it apart in pieces so that you can kind of arrive at the sort of jump off point for this protocol discussion. Okay, so the first thing that I think we should do is we should talk a little bit about the background of this particular protocol. And we did discuss this in a different context in the first part of the lecture, and that was in the context of a study published in Critical Care Medicine in 2007, in which they addressed this problem with a diazepam-based protocol, which was based on bedside assessment of patient sedation score and escalating doses of diazepam, followed by a phenobarb. Okay, so that was the first publication utilizing this type of strategy, and subsequently it gained a lot of traction, and a lot of people are using this, and most of the intensive care specialists that I know definitely are also doing the same thing. So this is a study entitled Alcohol Withdrawal Syndrome in Critically Ill Patients, and it's a protocolized versus non-protocolized management. Journal of Acute Care Surgery, or Journal of Trauma and Acute Care Surgery in 2014. So this was done at Davis, and this is a pre and post retrospective study, just like the previous one. And I think it's really important to keep that in mind, that this is a retrospective study. And we'll talk about a little bit why. The pre-group was basically a group that existed this was patients treated prior to the institution of this protocol, who received a benzodiazepine-based therapy based on institutional protocols. And this was largely boluses versus continuous infusions as per the physician's discretion. Now, after the institution of the protocol, so the post group, they received a escalating dose strategy diazepam-based benzo protocol, much like the one that we discussed earlier. Okay, so let's look at this. This is the intervention group. So what they did after the institution of this protocol is they suspected alcohol abuse and a cessation period, and they, embarked on a diagnostic evaluation. They were ruling out other causes. Of course, that's imperative in this patient population, is to rule out other causes and simultaneously evaluate for other comorbid conditions. And they would give them vitamins and other stuff, and then they would assess the patient's risk of withdrawal by performing a CWA score. And the CWA score, we briefly mentioned in part one, basically if they met criteria for moderate to severe risk, which is a score greater than 8, they were enrolled in this pathway. So the next thing they did is they went to the bedside and they assessed a Richmond agitation score. And we'll talk about that in a minute. If the Richmond agitation score was greater than 1, which is basically, a Richmond agitation score of 1 is when your patient is sitting there and they're pretty uncomfortable looking. They're not ripping their lines out, they're not delusional, they're not disoriented, but they're definitely squirming in the bed, and they can, plus or minus other symptoms, including disorientation and whatnot. But really, a RAS score of 1 is not hard to achieve. It's just the patient that is uncomfortable. If the patient had a RAS of 1 or greater, the MD would be at the bedside, and they would give them 10 milligrams of IV diazepam. Okay, and then they would reassess the patient 15 minutes later and calculate a RAS score. Again, if the RAS was 1 or greater, they would go back to the bedside and they would give 10 milligrams of IV Valium. Then they would go back 15 minutes later and reassess the patient, and if the patient had a RAS of greater than 1, they would give them 20 milligrams of Valium. So now that we're escalating the dose. And then 15 minutes later, they would do the same, give 20 milligrams of Valium. And then 15 minutes later, they would reassess, and if their score is high, they would go up to 30 milligrams, and then do that twice. And then 15 minutes later, if they were still in the treatment, if they were still requiring treatment, they would continue to escalate their dose up to 40 milligrams. Now, ultimately, they would get to a level of 120 milligrams of diazepam, which frankly is a fairly low dose based on other trials. But at that point, if their RAS score was still greater than 1, they would add phenobarbital simultaneously. Okay, so in this study, they gave 60 milligrams of IV phenobarbital in combination with the continued administration of diazepam. That's an important concept. So they were adding this on while continuing the escalation of the diazepam. Now with the phenobarb, they would reassess every 30 minutes, and then they would escalate that dose up to 120 milligrams. And all of the while, the endpoint is a RASS between 0 and 1. And once you get to that part, once they got to that point, they would just stop and they would treat based on symptoms, just in the same fashion. Okay, so that's the intervention group. And here is the results of the study. They included 18-year-olds and older with alcohol withdrawal syndrome admitted to the ICU. Remember, very important, these were ICU patients. Okay, so that's worth noting. Their outcome measure, they had a primary predefined outcome measure of ICU length of stay, and then they had a number of secondary outcomes. And at this point, I think it's worth noting that in this type of study, a retrospective kind of pre-post observational study, it's a little bit difficult to compare things statistically, such as need for mechanical ventilation or other hard, clinically important patient-oriented outcomes because of the statistical methods. You'd really like to see a randomized prospective trial, but this was done fairly well, and they have some pretty important findings, I think. So the results, there were 135 patients total. 75 were in the intervention group. And their primary outcome, they found a decreased ICU length of stay in the protocolized group, 9.6 days versus 5.2 days. And they also showed a decreased time on the ventilator, decreased need for intubation due to alcohol withdrawal, a decreased need for continuous sedation, and a decrease of duration of sedation, and a suggestion, a trend towards improved mortality. So the other thing that I think is worth noting is that I believe the average diazepam dose given to these patients was in the 80 to 100 milligram range. So it does provide evidence of really using sort of larger doses of benzos or diazepam than we're used to. Now, having said that, in this sort of retrospective study, it's a little bit of statistical gymnastics to report on so many of these outcomes. There's a lot going on here. Prior to the administration of the protocol, they were intubating people more. They were putting people on continuous infusions more, which is going to increase their ICU length of stay. And maybe in this post group, they were less likely to perform mechanical ventilation because of whatever reasons. Maybe there's just some cultural practice changes over this time interval. So it's, again, the point I'm trying to make is this is not the ideal method to report on these types of outcomes in this type of study, but this is a very excellent study, and this is what our protocol is going to be based on. Same sort of approach, just like we discussed in the diazepam escalating dose strategy with phenobarb adjuvant. Okay, so the author's conclusions of the study is that the study suggests a protocolized treatment approach using early aggressive symptoms-triggered dosing of diazepam and phenobarbital as an adjuvant in an escalating fashion based on bedside symptom scores is associated with decreased need for intubation, less time on mechanical ventilation, decreased ICU length of stay, reduced benzo exposure, and possibly decreased mortality. So that's a mouthful, and I think the key word is suggests. But nevertheless, very positive study. And this is not the first in this sort of method in this actually similar algorithm. So that's another thing. When observational trials start to say the same thing, the association becomes stronger. So in that regard, it's a bit of a validation study. Okay, so what patients meet criteria for this? This is actually quite easy. It really comes down to the attending physician feels that the patient meets criteria for treatment as an inpatient for moderate to severe alcohol withdrawal, with or without alternative diagnosis. The good thing about the Davis study, in contrast to others, is that they actually included patients who had a whole number of other things going on. Maybe alcohol withdrawal was not their primary reason for admission, such as the previous studies were done mostly just in the medical ICU for patients who had a primary diagnosis of alcohol withdrawal. So the most important thing about identifying these patients and initiating this protocol is you must be simultaneously evaluating and ruling out other causes of the condition. And this is a bit of a no-brainer, and it kind of goes without saying, but the clinical conundrum that is alcohol-related complications is infinite. And it has fooled all of us at one point or another, and it will again. And so it's very important to be vigilant with these patients. Hypoxia, sepsis, occult trauma. Trauma is such a big player in these patient populations. Metabolic and electrolyte disturbances. We just talked about some of them, including acidosis and some of the hypoglycemia states, but also the electrolyte and metabolic changes are profound. Hepatic encephalopathy and hyperammonemia, brain injury, overdose, tox, polysubstance abuse, medication effects, and also underlying psychopathology decompensations. And one of the probably the most common is pain. So like treating all of this stuff and evaluating for all this stuff simultaneously is so important. But once you get to the point where you think that alcohol withdrawal syndrome is a primary cause of the patient's condition that needs aggressive therapy, that is when you enroll them. Okay? So they must have a clear history of chronic alcohol abuse and some form of recent abstinence. I mean, the abstinence period widely varies, but you must have some form of abstinence because the presence of ethanol is, you're not going to have a patient who comes in directly after a large volume ingestion who is clinically intoxicated who is simultaneously withdrawing, is another way of looking at it. So they must be getting admitted to the hospital, and frankly, patients who meet criteria for moderate to severe alcohol withdrawal, they need to be admitted to the ICU for this protocol. Okay, so the protocol. Number one, do you think the patient has alcohol withdrawal? Is the patient going to the ICU? If yes, then considering starting the loading phase protocol. The first step in this protocol, after you have identified this patient, is to perform a SHOT score and a RAS score, and we'll talk about those. So the SHOT score and the RAS score, and you're thinking, oh, another scoring system. These are doable, and they are, once you get them committed to memory, you do this stuff from the door and from the bedside. So they're actually quite helpful. So let's talk about the SHOT scale. SHOT stands for sweating, hallucination, orientation, and tremor. Sweating, you get 2 points if you're dripping sweat. You get 0 if you're not sweating at all. And the clammy patient gets 1. Tremor, on the other hand, gets 4 points for severe tremor. And this, of course, is subjective, but you just look at the patient, and if they have a minimal tremor and it's not the big deal, you give them 1. If they're just, shaking the pulse ox off their finger, then they're 4. And orientation, if they have any level of orientation, they can get a point, and any hallucination also gets them a point. And it's at the bottom, at the end of the day, it's not hard to get a score of 5 on this scale. So when you do the SHOT score, that's going to characterize your patient as being either mild withdrawal or moderate to severe withdrawal. If they have a if they have a less than 5, you just treat them with a symptoms triggered approach. You can use oral agents, IV agents, you can use whatever you feel is appropriate. In the hospital, they will have a protocolized approach to this. But we're talking about the next category of patient in whom you suspect alcohol withdrawal, and you do a SHOT score and it's greater than 5. And if this patient has those 2 things, then you move to the IV loading protocol and plan to admit to the ICU. Okay, so let's talk about the Richmond Agitation Sedation Scale. And I know that everybody's groaning and like, oh, and I've heard, we talk about this one a lot. This is actually a really popular scale. And certainly it has been subject to some indication creep. It was originally validated in patients who were receiving sedation for mechanical ventilation and who were critically ill, and then was subsequently sort of crept out into the broader population and is now used for just about everything in the hospital. And it's been used and validated to some extent, and is very helpful. And the thing is some people at first glance like, wow, it looks very complicated and it's a lot of nursing and charting and takes some time, but really this is quite easy and it takes seconds. 15 seconds, I would say would be a reasonable estimation once you get used to it. So let's just go through it briefly, and we're just going to go through it really superficially. So the patient who is a danger to themselves, ripping their lines out, danger to self, danger to staff, this is a B52 patient, that is +4. An immediate threat and an immediate danger and needs to be chemically sedated. That's a +4. Very agitated is like the uncooperative patient who's going to pull their lines out, etc. That patient's is a +3. And then +2 and +1 are just sort of agitated, not really, they're looking around the room, they're tangential, they're not really focused, they're not participating in their care. 0 is alert and calm, you're just sitting there, you're normal, and you're conversant, and you're cooperative. And then you get into the sedation side. So -1 is just very lightly drowsy, opens eyes to voice, will maintain eye contact and conversation, but might close their eyes when you stop talking to them. And then light sedation and moderate sedation, light sedation is basically they will open to voice and respond to voice and light tactile stimuli, but they'll maybe fall back asleep. And then moderate sedation, of course, is a sedation level in which they are responsive to verbal commands and voice, but are quite sedated. And that's something we're real familiar with. And the deep sedation is no response to voice, but they will respond to noxious and physical stimuli purposefully. Okay, so it's actually quite easy. Your target is here, 0 to -1, and it's just what you would expect. You want the patient either resting, sleepy, or you want them just sitting there calm. Anything above that in terms of restlessness or agitation should probably trigger a dose of diazepam. Okay, so the way that this works is you get a shot greater than 5, then you go to a RASS, and if your RASS is greater than 1, then you treat, okay? If it's less than 1, and they still need symptoms directed therapy, that's kind of a different pathway where you're kind of giving PRN meds or maybe a chlordiazepoxide regimen. So that's a little bit of a different patient population. But the greater than 1 category, you walk to the bedside and you give them 10 milligrams of diazepam. And then after you give that, 15 minutes later, you calculate another RASS. And if the RASS is greater than 1, then you go back and you give them 10 milligrams of Valium again. And then 15 minutes later, you go back to the bedside and you reassess them, you calculate a RASS. If the RASS is greater than 1, then you move up to 20 milligrams. And then 15 minutes later, you readdress them. If the RASS continues to be greater than 1, then you give them 20 milligrams more, and you repeat that dose. And 15 minutes later, you go back to the bedside. If the RASS continues to be greater than 1, then you give them 30 milligrams. So you're walking up this ladder again, and you do that again 15 minutes later. Now, there's a little bit of caveat here, and recognizing the fact that it's really not practical to go back to the bedside every 15 minutes on the minute. You might go before 15 minutes, you might go after 15 minutes. You might not get back to the bedside till 20 minutes. But if you give a dose of diazepam and 10 minutes later they're jumping off the bed and you need to treat them again, then this recommendation is to just double the dose. But in general, you will. So there's a little bit of leeway there in terms of being able to evaluate this patient on the minute at 15 minutes. And then once you reach the 30 milligram per dose target after 3 steps in this algorithm, that's the time when you want to add phenobarbital. And I'm going to re-emphasize that you add phenobarbital. You don't stop the benzodiazepine, you add phenobarbital. And the way you do this is at step 4, you go back to the bedside if the RASS is greater than 4, and you walk back to the bedside and you give 40 milligrams of IV Valium, diazepam, but you also administer 130 milligrams of phenobarbital over about 5 minutes. So that's kind of the adjuvant role for phenobarb. And then 15 minutes later, you go back and evaluate them, and if they need treatment still, then you give them a dose of diazepam at 40 milligrams. You double that dose. But the titration for the phenobarb is actually 60 minutes. So every 60 minutes that you go back to the bed and you're still treating this patient, then you give them another dose of phenobarbital. But all of the while, you are walking up this escalating diazepam dosing load. Okay, so hopefully that's clear. I know it can be a little confusing. You're going to have to look at this and get a feel for it yourself. But that's kind of the gist of it. And then it's going to take a little bit of time, no doubt, to get people comfortable with some of the dosing recommendations here. But these dosing recommendations have been validated in multiple studies, and they are very well supported, including the dose of phenobarbital. Okay, so in summary, patients with moderate to severe alcohol withdrawal, they benefit from a protocolized approach, such as this, and there is some evidence that patients who are sicker benefit more from an aggressive escalating dose target therapy in which you are treating them until they reach a sedation level target that you want, rather than giving them, fixed dose therapy based on CIWA scores done every so often. So the benzodiazepines are the mainstay of treatment, and utilize this protocol if you feel the patient has significant alcohol withdrawal and is being admitted. So first thing, identify the patient. Do you think it's alcohol withdrawal? Do you think they need parenteral therapy? Do you think that they need an IV approach? Do a shot score if it's greater than 5, enroll them. Do a RAS score if it's greater than 1, then start giving diazepam in this escalating fashion and see where you end up. Your target is at -1, which is basically just a comfortable patient. And lastly, don't forget to rule out other causes of the patient's conditions, because these patients are the most confusing and the most likely to have underlying badness going on. So thank you so much for listening, and we appreciate your time. And if you have any questions, feel free to contact me. Thanks.